everyone to the third and final part of this wonderful series Angela has been putting on. As a quick review, she started kind of with her path and journey and the resources that she's used to answer these medical ethic questions in terms of our faith and practice in medicine. She then followed that with human dignity and married love, which was a wonderful precursor to this and kind of some of those very foundational theological doctrines and beliefs. And we got a lot of great questions there too. So now we are finally finishing the series with something that was inspired by our pharmacy training. So emergency contraceptives, but more specifically Catholic teaching on that. So we'll be covering that tonight. A brief overview is we will have an introduction of the order by Alonzo, so you can get familiar with us if you aren't already. If you are, then you get a refresher. Then I will introduce our speaker and the two wonderful panelists that we have joining us today as well. The Q&A session will follow the presentation. During that time, I do ask that you drop your questions into the chat box. That way I can make sure I'm asking them as they come. If we don't get to all of them, we will do our best to record them and then even get those answers out to you because they're all so engaging. So to get started, Alonzo is the chair of the Federal Association Auxiliary Committee. So Alonzo, please take the floor.
Thank you so much, Ria. No, everybody, I just want to welcome you on behalf of the Order of Malta Houston Region Auxiliary. This is very, very exciting, and this being our last webinar, it's been a fantastic ride. So just really quickly, so the Order of Malta is, I might be biased, but it's, I believe, one of the most interesting organizations in the world, because it's a lay religious order of the Catholic Church, is a sovereign state, meaning that it has its own passport, stamps, currency, and it's considered an independent subject of international law with embassies all over the world. And is also an incredibly large charity, right? So it creates a huge impact around the world in all the countries that it is present. Its roots really tie back to the 11th century. 15th of February of 1113 is when it was officially established by the papal bull by Pope Paschal II. Since the very beginning, it was known as a Knights Hospitaller, and it really served all the people that came to the hospital. So it wasn't just about Christians; it served Muslims and anybody that showed up. And the motto of the order is Tuitio Fidei et Obsequium Pauperum, which means defense of the faith and taking care of the poor and the sick. And what this webinar is trying to do, right? It touches the defense of the faith quite nicely. Just one line from our rules and commentaries that the order seeks to glorify God by promoting the sanctification of each member through his or her work with the sick, of the poor, and witness of the Catholic faith. So that kind of summarizes really neatly what we're all about. The Houston region is one of 32 different regions in the Federal Association, and the Federal Association is one of the 3 associations that are present and active in the United States. This webinar was created really, with a lot of work from Ria and company as an effort to answer, some of the pertinent questions relating to medicine and Catholic faith, and connecting kind of current and potential members to meaningful discussions and actions. So we've had some interesting discussions here, and I hope tonight we can have some of that as well. And then just lastly, before kicking it off, I just want to thank again some of the leaders who put it together. Ria, Jess, Taylor, even Father Luke, who helped a ton by reviewing some of the materials. And our hospitaller, who's like the head of our region, she's not here tonight. Her name is Kathy Hiltzi, but I also want to thank her. And with that, just thank you again for joining, and let's get started.
Awesome, thank you, Alonzo. So to get us started into the highly anticipated presentation tonight that we're also excited about, let me introduce our speaker. Angela Baalmann is a fourth-year pharmacy student, almost graduated, so I can almost say pharmacist, we're almost there, from the University of Kansas School of Pharmacy. She's currently located in Kansas City and will soon be moving to Chapel Hill, North Carolina, to start her PGY1 residency training at the University of North Carolina. She's pursuing a career as an academic and ambulatory care pharmacist and has had an interest in bioethics since starting her undergraduate coursework. This interest of hers has grown into a passion where she decided to enroll in the National Catholic Bioethics Center, or NCBC, bioethics certification in 2021. She loves the field of pharmacy and her Catholic faith and is excited to understand the complexities of moral and ethical issues surrounding our healthcare. Through her studies, she hopes to live out her faith and care for pharmacists as best as possible through her work as a pharmacist. Following her presentation during the Q&A, we do have two wonderful panelists. Cindy and her husband, Deacon Angelo, will be joining us. They are experienced pharmacists who both completed their PharmD education and residency training together at UCSF and currently reside in California, where they are involved within their diocese. So Angela, the floor is yours. And thank you everyone for being here.
Thank you. That was a great introduction. I'm going to go ahead and share my presentation here. So yes, this is the last presentation of the webinar series. I'm very excited and very glad that I've been able to share some information that I hopefully have helped some people understand some of these issues. And the last teaching tonight, it definitely is pertinent to pharmacy, or it's really pharmacy specific. And yes, it is the Catholic teaching regarding emergency contraceptives. And as Rhea mentioned, I'm going into academia, so I have objectives for this discussion. Hopefully by the end, you'll be able to describe some of the arguments around just beginning of life issues, specifically pulling statements and guidance from the ethical and religious directives, or ERDs. Hopefully understand some components of cooperation. There's a flowchart I'm going to cover, which is very helpful because it relates to this topic, particularly how I came across it within pharmacy. And then review some of the available emergency contraceptives, have some key takeaways that you can understand from our discussion, and then just briefly hit on their use in rape and assault, which would be a little bit different than the name emergency contraceptives using for contraceptive purposes. And when I thought about there's kind of two ways to think about it. You know, one, why are we learning about these kind of things? They're immoral. Do we really need to understand all the intricacies? Is that wrong, understanding them? You know, I know some people, you know, when it comes to like medical training and residency, they refuse to learn how, you know, abortions are practiced because they don't believe they'll ever, you know, perform them or ever want to know details about them. So there's that side of things, but then there's the other side of knowing what patients are using and being able to be informed on the dangers and some of the risks associated with those medications. Specifically, I just had come up, my sister-in-law volunteers at a pregnancy crisis center, and one of her clients or patients was asking about one of these medications that we're going to go over, and my sister-in-law didn't quite know how it worked, and she couldn't really effectively talk to that person about how the medication worked and was harming her, or wasn't in her best interest, and what potentially it was doing to any child she might be carrying. So that is one instance where, we're learning about these medications not to promote their use, but to understand how we can explain them to patients, explain what they're doing, and have patients make really informed choices. And we hope that they wouldn't make the choice to use these medications, but we'll get into that a little bit later. So just something I wanted to frame for this discussion, because I think there's a couple different ways you could think about talking about this. So as I mentioned, the ERDs, they come from the USCCB, and I kind of went over that in the first webinar. They're a really good source of guidance regarding medical issues for healthcare professionals. So specifically, issues of care in the beginning of life talk about part 4. It has several parts, and so this slide is all of the introductory material, which, if you know the ERDs, they kind of lay out each issue with just a backing of what they believe, a lot of different principles. And then the second part is more prescriptive, or what should you do and what should you not do. So this slide is just all the backing. So it starts talking about what we talked about last week, how dignified and we are as humans, and how our sanctity of our life is from the beginning to the end. They also talk about, the sexual act and married love and what it's ordered to, which we went in great depth into last week. So definitely check that out if you haven't. But that's how new human life comes into being, through the sexual act within married love and marriage. And so the document talks about how we're called to care for humans in all of these areas, and especially women and the children that they bear during pregnancy, before pregnancy, after the unborn. We're called to care for them as healthcare professionals in all of those settings. And within that, there's different ways that, again, man can try to change, what sex means or what the ends are. And so that comes with contraception and abortion. And what we already talked about last week is the church cannot approve or condone those practices because of, with contraception being the natural ends of sex and what they're ordered to, man cannot try to separate. And that's a discussion, but also abortion being, we cannot take an innocent human life. So there's a lot of different things with that. Definitely check out last week's discussion. Trying to shorten it's kind of hard, but that is something that the ERDs cover. And they also want to state that you don't have to be a Catholic to realize this truth. It's written in our human nature by the natural law that we can understand through our own intellect when we reflect. When we reflect on our human nature and our dignity, we can advocate for this to people who aren't Catholic and someone of any faith, just by the fact that they're human. And so this would be the other part where they kind of just lay down the law or kind of say Catholic teaching on what we will and will not adhere to. And so abortion is never permitted. It's an intrinsic evil that cannot be ordered towards any good. It is and always will be wrong. And the definition being the direct and intended termination of pregnancy before it's viable, or the destruction of a viable baby or fetus is never okay. So if you think about conception, it's when the sperm and egg meet and we have a zygote and a new embryo, a new human life, and that still has to go and implant into the uterine walls. So either, after it's there or once it's there, that would still both be considered an abortive act. So that is always wrong, and we can't even materially cooperate. I'm going to go over to what that means here in the next slide. But the evil is so grave, right? Taking the innocent life of a human being is so grave, we can't even cooperate materially. We can't cooperate with this evil act. So that's something that is very clearly laid out in ERDs. And yeah, I'm going to talk a little bit about that the point two on the slide later on, because it's something I had to kind of understand. And of course, contraception kind of comes with that. We talked last week about how they're two fruits of the same tree. Life is not wanted. So contraception, life is not wanted. When that's strengthened, if a pregnancy happens, the desire to go for abortion is even stronger because we already have a strong contraceptive mentality. So this is the flowchart that I found online, and I hadn't come across this until I was making this presentation, but the reason I bring up cooperation is because the reason I came across this topic had to do with my job as a pharmacy technician before I was even a pharmacy student. I brought this up in the first webinar series, but I was working as a technician, and we stocked PharmD, which is an emergency contraceptive, in the back. And I was responsible for, if a patient requested it, grabbing it, counseling them on it, and then dispensing it to them. And I realized later on that that was a form of cooperation with evil that was not just or not allowed, because these emergency contraceptives also function as abortifacients. And unlike oral contraceptive pills or hormonal pills or treatments, they don't have any other use. So there's no other indication for these medications besides contraception and abortion properties. So we already mentioned how we cannot even materially cooperate with abortion, and these have no other illicit use, right? No one's buying these emergency contraceptives for any other use that we can see, that would be justified in medicine. So it's a case where really no cooperation is allowed, as the ERDs state. So that was the situation I was faced with. But I just really had to dive into the subject of cooperation because I just didn't understand it. So this flowchart helps us kind of lay it out, and I'm going to go through it a little bit. Of course, it's a hugely difficult topic, and we actually just covered it in the certification program I'm in, and it was a tough assignment. Not sure I did that great, but it's something that's going to take me a while to even understand. So I like this flowchart because it helps guide discussion. So the first point, if the church forbids the action, then you don't even think about doing it. But if they don't strictly forbid an action or don't really lay it out very clearly, because cooperation can be very gray in a lot of different areas, a lot of different things, they may not have specific guidance for every single situation. The next step that you would think about is, do you contribute to the Principal Agents Act? And the principal agent will be the person performing the object of the act, or the person doing the act, right? You're cooperating, you're helping them in some way, but they want to know if it will contribute. So are you even cooperating? It's basically what this question is asking. If you're not even cooperating, then it's not an issue. But if you are, then you need to think about what the intent is. So if you agree with what the principal agent is doing, then you would be formally cooperating. That's the term. And formal cooperation with an evil act is wrong. So the classic example, you're robbing a bank, and you're the getaway car person, or sorry, someone's robbing a bank, you're the getaway car person, and you agree, you want them to rob the bank. You formally are cooperating with them, you're helping them, even if they're robbing the bank, you have the getaway car. So that's a form of formal cooperation. But let's say you didn't quite agree, you're still getting the getaway car. Let's say you're a taxi driver and you were hired to help these bank robbers rob the bank. You don't agree with what they're doing, but you are helping them. So you're a material cooperator. And so that is sometimes okay, but we need to go down to the next slide, or sorry, to the next point, because you need to think about how closely your actions are connected with the principal agents. So there's two forms of material cooperation, which would be immediate and mediate. Immediate is when you are very closely connected with the Principal Agents Act. And how it was put to me in this certification program is how many different steps or decisions have to be made between your decision and the principal agent's evil, act or decision. The more steps in between those two, the more immediate or far away you are, and probably the more moral or licit your cooperation is. That's very difficult to understand, honestly, for me. But if we think about the getaway car example, you're really, really close helping them literally drive the car away. It would be different if you filled the car with gas or if you aired up the tires. You're driving the car right after the bank robbery happens. It's probably immediate material cooperation. But in the other case, let's take the example of you're airing up the tires in the car. It could be mediate material cooperation. And so then the flowchart keeps continuing because this is a complicated topic. But if it's immediate material cooperation, then you have to think about scandal. So scandal is when your actions or your words or whatever you're doing leads someone else into sin or into error. The church is very concerned about scandal. It's very important to be a beacon of truth and light to the world, and making sure that we are a source of truth, and people look to us and know that we are doing good actions. So we would never want to lead others into sin. And so if something is causing significant scandal, and this is also something where you would need an expert to understand, if you're really causing significant scandal, you need to go to your priest or your bishop, then you would not do that action, because that is enough of a reason not to cooperate if you're going to cause significant scandal. If you're not, then if there's a proportionate good, it may be justified for you to cooperate. We live in a world of brokenness and sin, and we can't go our whole lives without touching any evil. We ourselves cause evil at times, as we sin. So we have to be cooperators in some aspects. We just have to know when and where to say yes and when and where to say no. So there are goods that we need to achieve in our lives, and to do so, we have to cooperate with others. But the good of, let's say, the person airing up the car's tires for the car that's going to drive the getaway car. And we're not going to talk about if the person knew or not that it was a getaway car for a bank robbery, because that's even more complicated. But that person was probably feeding his family and having a job, and the good of supporting his family. He may have been cooperating with evil, but again, it's material and it's immediate, and it's the good of him feeding his family and earning a living. So that's important to think about. And lastly is the connection to the act, proximate or remote. And again, I'm still hoping to understand this even better, but proximate would just be I'm very close to the act, or I'm closely connected in relation to like distance, or the act's happening right now, versus remote. The act already happened, it's very far away from me, and I'm so far removed from when it happened or where it happened. That's kind of how I understand that. So I guess the person airing up the tires, if it's the day of the robbery, that person is very close to the act. Maybe it was right before they go to rob the bank, but let's say they aired the car tires up about 2 weeks before. It's much more remote. So, and then they talk about how the evil act compared to the good effect achieved by cooperating, which kind of talks about the good that you're preserving. But I really like this flow chart because it just helps remind us what all we need to think about when it comes to cooperation. I myself am still delving into so many things relating to pharmacy and how we either cooperate morally or immorally, because just such a complicated topic, very interesting, and one that, I'm just going to continue to use this flow chart and think about. So we talked earlier about the different ways, I guess, abortion can occur. Once conception has occurred, we can stop the process of implantation, and that would be considered an abortion because there's still a new human life. Or once implantation has occurred, disrupting that process and stopping the viable pregnancy from occurring. And ACOG, or the American College of Gynecology, Obstetrics and Gynecology, is a governing body that talks about things like pregnancy and reproductive health and provides guidelines and guidance and statements. Their definition of fertilization is when egg and sperm meets and it makes a single cell. It's the first step that leads to pregnancy, where the cell divides into multiple cells. And we believe that, and many, I Catholic/biology, because science and Catholics would agree that it's when sperm meets the egg that a new life begins, even as it migrates to the wall to implant. It's something that I think just gets lost. It gets lost in when this actually occurs. And I'm going to talk here in a little bit about what ACOG says, but I had to go back to the roots of like these biology textbooks and things like that. And I found a great article that I linked here in the PDF that I will share, which gives the in-depth scientific argument for it. That's not Catholic, but something that designates a new species or a new life, that something's different, is that it has a different structure and it has a different function. So a new zygote or a new human being is made up of different things and does different things than a sperm or an egg. That's how we know it's a new species, it's a new life. And so I love how that document just laid that all back out for me. I didn't have to try to ask my parents where my middle school textbook was, but it went back into the science of things and just how these definitions come about. And definitions are very important, especially when it comes to pregnancy, because what ACOG will put on their website is that, put in their guidance, is that 8 weeks after implantation, right, of the new baby, we would say, but they would probably say zygote. 8 weeks after it's implanted, it's still an embryo. And then 9 weeks after it's been implanted, it's then a fetus. So it's saying that even for 8 weeks after the new life is implanted, it's still not considered a fetus, which would be, I think in their terms, a human. Which is really sad, because that gives a lot of leeway for all of these drugs to be used and not be considered abortifacients. It defines how drugs are regulated, how they're paid for, with government funding, funding for abortifacients and contraceptives, which is a whole other discussion, and it informs patients and physicians and pharmacists. So that definition is very, very important. And it's one that I had to learn when learning about these emergency contraceptives, because I got a big old slide that said, these are not abortifacients. And I thought, it doesn't make sense to me. And that's when I reached out to my teacher and explained the definition of pregnancy and what they define as pregnancy. So again, I would definitely read that article if you have time, because it's not a Catholic article and it's very scientifically based and something I think goes back to the science and help me understand things. But Stephanie Gray is someone I mentioned in the first webinar, and she's a very pro-life speaker and advocate. She's also Catholic, but she gives a lot of good debates that are very non-religious and kind of go back to the science of things. And I love how she puts a lot of things. She says, what else do you think would be there besides a human? What else do we make as humans but other humans? So she gives a lot of great arguments that I love. So this slide, I guess the citation would be from my NAPLEX study book, but for emergency contraceptives, they're hormonal based and there's non. But technically they're indicated for after unprotected sex to prevent pregnancy. There used to be kind of a practice where normal contraceptive pills would just be used at very high doses for emergency contraceptive purposes. But they had a lot of dangers with them, a lot of contraindications, a lot of nausea and vomiting. So for about 30 years, they've kind of tried to formulate these other class of emergency contraceptives rather than using normal contraceptives at very high doses. They don't have a lot of contraindications, so safety will be something that's touted a lot for these. And technically, we are going to talk about a little bit, it's for unprotected sex or even sexual assault. So that's kind of the uses there. And we're going to cover three. The first is this copper IUD. So this is also a contraceptive people can have, but it also works as an emergency contraceptive if needed. This is a non-hormonal, and the mechanism of action is not well defined. It does interfere with the fertilization process, but once implantation has occurred, it rarely is viable. Even on our drug resource known as Lexicomp, it said even when fertilization does occur, it doesn't develop normally, which is very scary to think about. So this one has a lot of efficacy associated with it and definitely doesn't allow normal human life to occur. Technically up to 5 days after unprotected intercourse, and it has to be something that a patient or a person would have to go to a clinic to get. It would not be over the counter. This is a newer emergency contraceptive. I want to say it was approved a couple years ago, called Ella, and it's kind of similar to mifepristone, which is RU486, the abortion pill. It prevents progestin from binding to its receptor. Doesn't have as much potency as the copper IUD, but it stops ovulation, prevents implantation, so it does have the abortifacient properties. A couple different of these emergency contraceptives, like the further away you use them from the Unprotected Sex Act, the less efficacy they have. But this one does require a prescription, so they would have to go to a physician to get this, and there's some side effects there. Technically, women are only allowed to use these one time per cycle because it can cause some dangers if they frequently use them. And the last one we'll cover is the one that I personally had experience with, which is levonorgestrel or Plan B, commonly known as the morning after pill, or My Way is another generic brand that you'll see a lot. What it does is prevents ovulation, it thickens cervical mucus, which prevents fertilization, and then also once implantation has begun, it can cause abortion by disrupting the lining. So it's 89% or kind of less effective than the others. It's technically the least effective of the options, up to 3 days, and so not as long as the other ones. This is not prescription again, it's over the counter. There's no age or any other restrictions on this one. So I think some grocery stores or pharmacies will have them locked up, but technically there's no restrictions, anyone can buy it. Its potential to cause nausea is pretty high. And so you have to repeat a dose, a woman would have to repeat a dose if she were to vomit it up. So that's kind of another consideration, I guess, to think about. This one is the one that there's more and more studies coming out that say that maybe it really has no effect on implantation. So maybe it really has no abortifacient properties. It's just by the mechanism of how it works as a progesterone. Usually the estrogen component of contraceptives have more of that implantation disruption, so the abortifacient property. And as I was talking with my teacher about this, she said, FDA labeling is very controversial. So you'll see still on the package for this that it has abortifacient properties, but she said that might even be changed. And something I just think about, I read the studies that she gave me, they have a 1 or 2% abortifacient rate or property. And I guess to me as a clinician, that's still nothing that I would wish to have happen. And we can talk about that a little bit later, but it's just gray. I guess I just want you to know it's gray, and it may be changing in the future because of new studies and new labeling. So to summarize kind of what we talked about, the use of emergency contraceptives is not okay. It's not a good moral decision that we can promote or allow. They have abortifacient properties along with their contraceptive properties. And so we cannot cooperate with that as healthcare professionals. That's going to change depending on where you work, what your role is, different for physicians, recommending them or, not recommending them, nurses and wherever else you work. They're given technically in a lot of different settings, and I just know them from my outpatient retail setting. Yeah, it's going to be a lot different how your cooperation looks, and you're always going to have to talk to someone in the field or talk to someone who's educated in this area, as far as I can tell, because it's going to take a lot of assessment and people who know these issues well. And so just one thing I wanted to touch on, because I felt like for completeness sake of this discussion, I wanted to bring it up. Technically, in the ERD part 36, they talk about women who have been raped or sexually assaulted. They should be allowed to defend themselves against potential conception if after they've been tested, there's no evidence that a new life or conception has occurred. They can treat with medications to prevent, the fertilization process, but they can't, again, no abortion is allowed, even in the case of rape or assault. So that was something I hadn't really thought about, because yeah, in this case of a woman being raped or assaulted, she's not necessarily contracepting because it wasn't a free act that she gave of herself in that act. So she's instead doing an act of protection, not wanting to further her attacker's intrusion by having her become pregnant. So the question then arises, how can we be sure that she's not pregnant? Or how can we be sure that she hasn't ovulated yet, things like that? So it's tough. It's a tough discussion, and there's a lot of different ways you can tell if a woman has ovulated or not. There's LH methods. There's, if the woman knows her cycles, if she knows what's going on, a doctor could kind of try to assess. She says, yeah, I'm not, there's not a big chance that I could be pregnant. Could this medication be used? And after just thinking about this more, we would never want abortion to occur. We have to realize that there are illicit means of using these occasionally. And unfortunately, medicine and science is not 100% accurate. It's not math, or it's not other things where we can be 100% sure. We have to have what's called moral or prudential certitude. Based on the knowledge that we have, we can act with good conscience or with a good intent, and do an action, even if we're not 100% sure. And we do that a lot in medicine. We're not 100% sure that a drug will help someone. There's a risk that it won't, or there's a risk it'll cause a side effect or a really negative effect. They'd have an allergy. We never act with 100% certainty. And this is one of those areas where we'd want to counsel the woman greatly on what the options are against, on what she's doing, and try to get a full history and get a good assessment. But in certain cases, it may be licit to use Plan B. In the case of rape and assault, if we've done enough collection and we're pretty sure, very sure, we have moral or prudential certitude that the woman is not pregnant, and that it would be okay for her to, again, protect herself in that area. So I know there probably are questions about that, because that was something even I had to look into a lot, but something I wanted to touch on. So significant questions kind of coming from this discussion. The first one honestly comes back to that last webinar that we had, because it relates to this topic. The one that we talked about tonight really more is, what do you think your profession's role, if you're in the healthcare field, what is your role in cooperation with evil when it comes to these two intrinsic evils? What do we believe about the truth of the beginning of life when new life actually occurs? What is an accurate definition of conception and of pregnancy? And that what uses are there for emergency contraceptives for your future patients? Hopefully none, except in the case of possibly rape and assault, and probably in a setting of a hospital or something that has a protocol relating to this, where you can follow and be sure that you're doing enough assessment and enough gathering of that information to make sure you're acting in a moral way. So with that, I will stop my share and open it up for questions.
So thank you so much, Angela. Again, this is the time where we will ask you to drop your questions into the chat box. Angelo and Cindy are with us. Cindy, while we wait for a few questions to come in and stuff, I wanted to ask if you had anything that you would also like to provide in terms of insight or experience.
Well, first, let me say I'd like to thank Angela for the very nice and thorough overview. I felt like I was back in class again for our program. but I thought she gave a very nice review of the topic. And I think there's going to be times through our career when we are faced with these questions, and it's nice to be prepared and be thoughtful. And what I appreciate about what Angela shared today was that, what do I want to call it? The decision tree, right? So that when we're faced with these situations, sometimes it's overwhelming in terms of the feelings we might have about how we might react. But if we remember that there are resources like that that can help us carefully review and question. And then once we make a decision, you know, we can feel good about the process that we used rather than being in a panic, right? So that was very helpful, and a reference I hadn't seen before. So thank you, Angela.
Yeah, it's a Google search and I thought, where's this been? I'm so glad I have this flowchart now.
And it's on the internet, so it must be true. Right?
It's a Catholic website, but yes, you're right. We should be cautious.
Awesome. So we've got a question for you, or both of you. If an emergency contraceptive was found to not affect implantation, making it not an abortifacient, would that open it up for use within Catholic hospitals and clinics for emergency contraception, if we knew for sure?
So I would say, I think Plan B comes the closest to that from what we are understanding. As more evidence comes out in the terms of actual abortion rates with it, I think that would be the closest we can come to. But in terms of these hormonal treatments, like unfortunately, they're never 100%. And I think women fluctuations with their reactions with these meds are it's very variable. So it's tough, I think, even like to have a protocol in a hospital that you really can have that moral or prudential certitude. But I think for my certification, when I asked this question, he said it seems that it could be justified if they've done their due diligence and they kind of have those tests in their protocol at proper times and things. So only in the case of, again, that rape or assault would it be okay, where we could use it, because again, that is a case of a woman defending herself against conception from her attacker. And we would have to be sure, I guess if they didn't cause any abortifacient properties, then we could use them maybe with a little bit less of the protocol considerations, but definitely not in the other cases of a woman who had unprotected sex and just does not want to get pregnant from it.
Right, in those special circumstances.
Awesome. So we have a 3-part question here. So I will read the whole thing and then just ask me to repeat, just like we've learned. So, are there current efforts to ensure individuals are appropriately advised of the illicit possibility of the limited use situations you mentioned regarding prevention of fertilization? How can we ensure individuals are advised of those situations in catechesis or in those actual situations? And are there professional standards of conduct that require advising the patient/victim of that?
You're going to have to repeat the first part for me, I think.
Yeah. Are there current efforts to ensure individuals are appropriately advised of the illicit possibility of the limited use situations you mentioned regarding prevention of fertilization?
So I assume that person means, like, in the case of rape or assault, like how sometimes they're potentially okay. Are there efforts to do that? I didn't come across them. There probably are groups, or, again, I'm taking the certification and that's educating me, but it's something I chose to do. So, and from what I understand in the world of pharmacy and in pharmacy schools, Creighton is the only Catholic pharmacy that has that designation. And I asked, I have a friend who went to Creighton, she's Catholic. I found a couple Creighton pharmacists at Mass, and I asked them kind of what the difference was between their education when it was Catholic, when it was not. And they told me they kind of had some NFP training, and they had this article given to them that I mentioned, the in-depth scientific argument, but probably not a substantial discussion Plan B, and possibly because, again, it's emerging. There's kind of, with these areas that are more new or gray, the church doesn't make a definitive statement. We just have to look to a lot of different moral theologians who have written, documents about this and experts in the area. So there probably isn't enough, is my guess. And certainly for me, I guess in my secular pharmacy school, there wasn't. But the second question is, how can we? Is that the second question?
Yes.
We do so. Yeah, I mean, my goal is to start a student group talking about these issues and educating on them. So that's my way of doing it. It's these webinars, it's these postings on websites that people can refer back to. I would hope that we can get, like you mentioned, this is partly for community building. We can get other individuals to spread the word when these questions are asked. And the third question part, I forgot already.
Are there professional standards of conduct that require advising the patient or victim of these unique situations?
I think it would depend. I think it would depend in terms of, you mean like a legislated per the law or a Catholic law? So, I mean, the State Board of Pharmacy definitely would have some regulations in terms of what sort of information patients are supposed to be provided. But in terms of the moral teachings around that, I think, like Angela mentioned, that's certainly not something that I learned about through the University of California. So that required to go outside of that system and take that extra step. So, here's the clinical information that we're educated on, here's the science, but then it required that extra step of finding out what the church teaching were to put on top of that. So here's the science, Cindy and Angela, here's what we're teaching you. And then going on our own and discerning what the moral part of that question is.
Yeah, and probably what makes it more difficult is the science may be changing. When we kind of see the progression of the definition of pregnancy, that alone has changed. And so it makes things a little more difficult. So there is another question. Can Angela or Cindy tell us more about conscientious objection as Catholic health practitioners?
Do you want to start, Angela?
Yeah, I can start. I think what the person's asking is like how we can, as healthcare practitioners, make sure that we are not cooperating immorally, and how we can object within our jobs. Funny, I just called my residency today and asked them to make sure that I'm not involved with any of the approval or dispensing or counseling on contraceptives or I don't think I'll touch abortion in my residency or transgender medicines, because I don't agree with them morally. So I had that discussion, and they are going to, reach out and make sure that things can happen. So I thought about this a lot, because it's kind of a great, pharmacy is a new area in my family. I have a lot of physicians in my family, but not pharmacists. So having to have those conversations in a different way, because I wasn't sure what I was going to encounter, because our roles are not so clear cut within pharmacy. They kind of changed where we're practicing. So I chose to be very upfront about it as soon as I could. I didn't mention it in my interview or in my other processes of residency prep, but I am going into this job. It'll be my first job as a pharmacist. And I wanted to be more upfront and make sure that they understood where I was coming from. We do have laws protecting us, religious protection laws. I have a couple names in my head, but I honestly need to understand them a little bit better. But the way I understand it is that businesses have to reasonably accommodate for us, or have to make an attempt to, if they can, they have to try to make an attempt to allow for us to have these religious protections of conscience. And when I had the discussion today, I didn't even bring religion into it. I just said it violates my conscience to do those acts. And so that's why I'm requesting it. So, but I could appeal to those, if needed. And yeah, I think it's tough, because we need good Catholic people who want to help people in every area, even the ones where it's really difficult. So you kind of gonna go where God's leading you in terms of what kind of patients you want to see. With me, it's not personally like the OBGYN route, but I still know I will have probably areas where I'll have to touch the contraception and transgender medicine part, but that's how I've decided to do it. But Cindy, you can add.
And Angela, you might recall when we first met, this was something that you and I spoke about, this very question. So I don't know if this question was plugged in prior to the program, but that's definitely something that we had talked about before. So I think what's important is that just like Angela talked about, is that you're very upfront with your employer and state what those objections are beforehand. Because I think where people get in trouble is, or when there's conflict, is when a situation comes up and you haven't stated that this is something that you're not in agreement with, and then you say, no, I can't do this. So I think if you're very transparent about what your feelings are, and I appreciate, Angela, that your approach that you took and said, this is, you didn't make it a religious thing. This is just who you are, right? So I think that was a really good move. Well done.
Thank you. And I think about like residency is such a different area. It's like applying for a job, but also being a student. And I felt like, when do I appropriately bring this up? I don't know. And I kind of feel like I should have brought it up even earlier, but again, I'm not going into those OBGYN areas specifically. I'm not like wanting to study that and be really a practitioner in that area. So maybe if I was, I should have brought it up in the interviews because that would have been more appropriate. But the reason I chose not to bring religion into it, I mean, I'm sure people will know that I'm Catholic once I get there. I wear a lot of cross necklaces and stuff like that. But I do feel very strongly that I need to build the skill of explaining all of these, all the natural law aspects, and not even bringing Jesus into the situation firsthand, because I do feel like I should have a strong ability to argue all of these things from a natural law standpoint. So that's kind of the reason I did that too.
And the science supports you. I mean, what I appreciate about how you started this today is you talked about the science, right? So what is it that we're actually talking about? So, yeah.
Awesome. So we'll do one more question. So how can the healthcare practitioners contextualize the Hippocratic Oath from the Catholic perspective in terms of contraceptives?
Wow.
I'll have to Google the Hippocratic Oath because I know it's changed. I know they've changed it over the years. So maybe if that person could say what specifically they meant, because we don't recite the Hippocratic Oath as part of our pharmacy anything, unless Cindy, did you when you were? Okay. And I know it's changed because that's one of the other problems. I think there's a Catholic medical group with physicians, and they even recite the old or the more ethical Hippocratic Oath. So I apologize. I don't really know how to answer that question offhand because I don't know the oath.
Can the person share? We don't mean to call you out.
Yes, good evening. Thank you Angela for your presentation. It's wonderful. My name is Henry. I'm from the Cuban Association of the Order of Malta, and I regret not being present in the previous presentations. I think it's very important as Catholics to know more about bioethics. And so I know that the pharmacists didn't take the Hippocratic Oath. So I found quite interesting the perspective of a health care professional as a Catholic. How would he or she envision, contextualize this Hippocratic Oath, primum non nocere, above all, do not harm, in terms of contraceptives? Because it can be a little bit confusing, right? It's not harming the woman that is taking the contraceptives, in theory, because there are collateral damage to that, but the person of the fetus, the new person that has been created when conception took place, how can we avoid seeing that miracle, that fact, as a human, in terms of applying the oath that has been taken by healthcare professionals?
So, Henry, what I appreciate about what you just said is the perspective of that statement in the context of who we doing harm to. So when we think about contraception and harming not only the woman, but also the life within her. So if we take do no harm and look at it from the perspective of the unborn, how does that show up, right? So how could it ever be okay?
Yeah, and I think it's all going to be individual. Some patients will be maybe understand that it's a new human life from conception. Some people won't. So that's the first place to start, what they identify, because I had to take my understanding of, again, that process between conception and implantation. Both are abortion. So if you disrupt either process, so I still had to understand that. Again, in pharmacy education, I don't really know. I haven't had a lot of experience talking with patients about this, but what they even understand about it. Because again, I don't think a lot of people think about it. Not a lot of people are in the medical or science field, so they don't even think about the biology class that they had all the way back in middle school and what it meant to designate, new species and new life.
Well, thank you all so much for your questions. I think this was very engaging. I wish we had more time to, of course, go more in depth on, all of the questions and the science and the theology and the back and forth. I think this was kind of a great show that when we say we're not going to do harm, the definition of what the non-Catholic or non-Christian medical community thinks doing no harm is different from ours, because those definitions of life are so important to make sure that we have correct. So as you go out there, I think what Angela said is great. Make sure you know your science. Really, really, really know that. Because when you can speak that same language with your colleagues and really understand it in depth, then you can also show and practice your faith through your knowledge.